You have appendicitis. Here's what will happen next. You have been told that you have appendicitis. At that moment, most people think the same thing. So, when is the surgery? What often surprises patients is that the answer is not always right now. That uncertainty is what many people find most unsettling. In this video, I will explain what usually happens after the diagnosis, step by step, so that you can understand how decisions are made and what the next phase of care typically looks like. No symptoms, no advice. Just what typically happens next. Once appendicitis is diagnosed, the most common next step is surgery. In straightforward cases, that decision is made quickly. However, there are situations where the plan is different. Not because something is being missed, but because the situation is more complex. This usually happens when the symptoms have been present for several days and abscess has formed, which is a localized pocket of infection. When the diagnosis is still uncertain, or when the findings raise concern for something other than simple appendicitis. In those cases, the focus shifts from speed to accuracy and safety. Some patients are admitted before a final decision about surgery is made. This usually happens when the diagnosis is not yet fully established. In many cases, a careful clinical examination is enough to make that decision. In others, however, additional information is needed. That may include imaging, such as a CT scan, or in younger patients, an ultrasound. During this phase, the goal is not to wait. The goal is to reach a clear diagnosis in a safe and structured way. Once that diagnosis is established, a decision is made whether to operate or not. If the diagnosis is not yet clear, clinicians are primarily watching for change. Most importantly, they are assessing how the pain behaves during repeated physical examinations. Pain on palpation, worsening tenderness, or signs of peritonitis, which is irritation of the lining of the inside of the abdomen, carry far more weight than any single test. Vital signs are followed closely, but on their own, they are rarely decisive in the early phase. Laboratory results usually change slowly, and over a few hours they often provide very limited new information. Throughout this period, pain is treated, but carefully, with the goal of keeping the patient comfortable without obscuring important clinical signs. Once the decision to operate has been made, surgery is usually performed as soon as possible. However, hospitals care for many patients at the same time, and some operations are more urgent than others. Your surgical team will decide within what time window it is safe to proceed. And if that window narrows, the operation is moved forward. Appendectomy itself carries a low risk of complications and remains the most definitive treatment. Non-operative treatment with antibiotics is sometimes used, but the risk of recurrence is significant. For this reason, and particularly in older patients where further evaluation such as CT imaging or colonoscopy may be needed, surgery is often the preferred option. If surgery is not performed, treatment is usually based on antibiotics and close follow-up. Surgery becomes urgent when the infection is no longer contained. This is when bacteria spread from the appendix into the peritoneal space, and in more advanced cases into the bloodstream, which is sepsis. At that point, surgery is almost always the only safe option. Postponing intervention in this situation is associated with much higher risk and a significantly slower and more complicated recovery. The priority is no longer observation or timing. The priority is rapid source control, meaning removal of the source of infection as soon as possible. One of the most unsettling experiences for patients is how quickly plans can change. We'll observe can turn into we're operating today. That shift does not mean someone was wrong earlier. It means new clinical information has emerged. Throughout this process, the surgeon is continuously reviewing all available information. Physical examination, test results, imaging, and how you are doing in a clinical sense. Patients do not always receive or retain all this information at once, especially during stressful situations. This difference between how decisions evolve and how information is communicated is a common source of confusion. Surgical care is therefore a process of continuous reassessment, not a single fixed plan made at one moment in time. Appendectomy is most commonly performed using a laparoscopic approach. In some situations, an open operation is chosen, either from the start or during surgery. This is to provide better control and safety. The guiding principle is always the same. The quality and the safety of the final result matter more than the technique itself. The operation is performed under general anesthesia. After surgery, you wake up in the recovery area. Once you are alert and stable, you are transferred back to the surgical ward for continued care. During this phase, vital signs are monitored. The team looks for basic signs that the body is recovering as expected, that you can move, that you can tolerate food, and that the bowel function is returning. Depending on how advanced the inflammation was, antibiotics may not be needed at all, or they may be continued for a short, defined period. A common postoperative symptom after laparoscopic surgery is shoulder pain. This is caused by temporary distension of the abdomen with carbon dioxide. This leads to referred pain, where irritation inside the abdomen is felt elsewhere in the body, not by positioning during the operation. In some cases, surgery is not considered the best initial treatment. Management then focuses on intravenous antibiotics, meaning antibiotics given directly into the bloodstream. In selected situations, drainage of an abscess, which is removal of the localized pocket of infection, may be required. In other cases, the findings raise suspicion of an underlying condition, such as a tumor, that may warrant further diagnostic evaluation before surgery is considered. Recovery in these situations can be more difficult to predict. Expectations and next steps are therefore communicated on an individual basis by your treating team. Many patients expect certainty once a diagnosis has been made. In reality, appendicitis can present in different ways. Symptoms may vary, and the position of the appendix itself can differ between individuals. A retrocecal appendix, where the appendix sits slightly further back, may cause less typical symptoms and present later than expected. These variations create real diagnostic challenges, not because of failure in care, but because the human body is complex, even in what is considered a common surgical condition. There are also situations such as appendicitis during pregnancy, where diagnosis and management follow a very different set of considerations. Uncertainty in these cases reflects biological reality, not a lack of clinical attention. If you have been diagnosed with appendicitis and the process feels slower, quieter, or more uncertain than expected, then this is usually why. The goal is not speed for its own sake. The goal is to ensure that the right treatment is chosen for your specific situation. Reaching that decision can take time. Throughout this process, clinicians are continuously reviewing how you are doing and integrating all available information. This video was meant to answer the most common questions patients have after diagnosis. Not advice or instructions, but with an understanding of how clinical decisions are made. This video is for general educational purpose only and does not replace individual medical assessment or care.